Hello everyone, welcome back to the series of lectures in cardiology. Today we will be discussing about the localization of myocardial infarction and the management of myocardial infarction. Okay, so let's proceed. First, let us understand what is the mechanism of ST segment elevation or depression in the ECG of an MI. So what is the mechanism? So as you can see here in this line diagram, a ST segment elevation myocardial infarction is characterized by transmural involvement. It is characterized by transmural involvement. So when there is a transmural ischemia, what happens to the flow of current? The flow of current will go from the endocardium to the epicardium, and as we know from the basics of the ECG that any current that flows towards an electrode, will be recorded as a positive wave, correct? So in this transmural, whenever there is a transmural infarction, what happens is that there is a delay in the ventricular depolarization. So there is a delay in the ventricular depolarization, and the segment which becomes affected is your ST segment. So there is a ventricular depolarization delay because of the infarcted portion, and during systole the ST segment becomes elevated. Now when the ST segment becomes elevated, at the same time the repolarization also becomes delayed. The repolarization of both the atria and the ventricles become delayed. So the PR segment also gets depressed because the flow of current is in the opposite direction and the PR segment gets depressed during diastole. See, on the whole you get a new baseline with a PR segment depressed and an ST segment apparently elevated. So that is the mechanism of ST segment elevation in a transmural infarction or in a ST segment elevated myocardial infarction, which is your STEMI. Now let us look at the difference when there is only a subendocardial or only a portion of the myocardium is affected. So this happens in an NSTEMI. This happens in an NSTEMI, as we have learned from the pathological discussion and mechanism of NSTEMI, when there is a plaque erosion. So what happens is that the flow of current is from the epicardium to the endocardium. So it is moving away from the electrode. So what will happen is that you have the exact opposite changes on the ECG, which appears as an ST segment depression. Okay, so this is the mechanism of ST segment elevation and ST segment depression in myocardial infarction. Now let us understand the coronary blood supply. Okay. Let us understand the coronary blood supply and how do you localize the myocardial infarction on the ECG. Now, let us look at this image. This is showing you the coronary blood supply by the right coronary artery. Okay. So, the right coronary artery gives off its first branch to the SA node, followed by which it gives out multiple atrial branches. It descends downwards and continues as the marginal artery which supplies most of the RV. A branch of the right coronary artery which goes in the posterior atrioventricular sulcus and then comes down in the interventricular sulcus is the posterior descending artery. This is the posterior descending artery. Okay. So, the most important branches and supply of your right coronary artery is your SA nodal artery, atrial branches, the marginal artery which supplies the right ventricle, and the posterior descending artery. Now, this posterior descending artery is one special artery because it can arise either from the right coronary or from the left coronary. In 85% of the patients, the PDA arises from the right coronary. So, if it arises from the right coronary, this is what we call as a right dominant circulation. Okay. So, which are the walls which are supplied by the right coronary? It is mainly the inferior wall, the right ventricle, and if the PDA arises from the right coronary, it supplies the posterior wall as well. Okay. So, the walls which are supplied by the right coronary are the inferior wall, the right ventricle as well as the posterior wall. Okay. Now, let us look at how the lesions at each level cause different changes on the ECG and different types of MI. Okay. So, first let us look at RVMI. Let us look at RVMI or a right ventricular MI. So, if you see here, if the lesion is proximal most, which is denoted here as 1. So, the proximal RCA is the one which gets affected, or if the thrombus is at the level of the proximal RCA, you get an RVMI. Okay. So, that means that all the branches which are descending from that are affected. So, what are the features of RVMI? It is very, very important. The triad of RVMI is hypotension, elevated JVP and clear lung fields. Okay. So, what are all the features that you expect to find? So, you know that the SA nodal artery will be affected because the lesion is proximal to the SA nodal artery, or in other words, it is in the proximal RCA. So, you can have bradycardia, okay. Then the atrial branches can be affected, right? So, the atrial branch supply is also cut off. So, this can result in a lot of atrial arrhythmias. So, you can have atrial arrhythmias. Okay. Apart from that, the entire right ventricular wall and the inferior wall is also affected. It can result in an inferior wall MI plus posterior wall MI, especially if the posterior descending artery is also arising from the right coronary artery. We all know that inferior wall MI is associated with hypotension. Okay. Now, what are the changes that you will see? So, this is an ST segment elevation MI. This is an STEMI. So, how do we localize a RVMI on the ECG? We will be looking at it shortly thereafter. Okay. Then, second, when the lesion is in the proximal part of the posterior descending artery, that is, the lesion is involving only the posterior descending artery when it is arising from the right coronary artery. So, in a right dominant circulation, it can result in an inferior wall MI along with the posterior wall MI, because the PDA supplies the inferior as well as the posterior wall. Okay. Now, let us look at how the leads are placed and which walls are supplied by which coronary arteries, and then look at the ECG findings. Okay. So, before going on to that, let us learn the left coronary circulation as well. So, the left coronary circulation is characterized by the origin of the left coronary artery. The left coronary artery is called as the left main coronary artery. The first branch of the left main coronary artery is a long branch which is called as the left anterior descending artery. From the left anterior descending artery, you have another branch which basically winds around and goes posteriorly, and it is called the left circumflex artery. You also have an obtuse marginal artery. Now, you see that in 25% of the patients, in 20 to 25% of the patients, the posterior descending artery can be a branch of the left circumflex. As you can see here, the posterior descending artery can be a branch of the left circumflex. So, if the posterior descending artery is a branch of the left circumflex, then it is called a left dominant circulation. So, which are the walls which are supplied by the left coronary artery? We have the anterior wall, the septum, and the lateral wall. And if the PDA arises from the left coronary, the posterior wall can also be affected. So, the main walls which are supplied are the anterior wall, the septum, and the lateral wall. Okay. So, now let us focus on this image. So, this image basically gives us how the leads are placed and how the leads are looking at the different walls or the different surfaces of the heart, and how the corresponding ECG changes will be. Okay. So, let us look at V1 and V2. Can you see from the diagram that the ECG leads V1 and V2 are the chest leads, right? So what are they looking at? They are looking at the septum. So septal leads are V1 and V2. Okay. Now let us look at the lateral wall. Which is the lateral wall? We can say that this is the lateral wall, right? This is the lateral wall. Fine, this is the lateral wall. So which are the leads which are looking at the lateral wall? So you can see that V5, V6, 1 AVL, right? This is the high lateral wall, which is 1 and AVL are the high lateral wall. V5, V6, 1 and AVL are the leads which basically look at the lateral wall. Now, which is the anterior surface? So you can tell that this portion is the anterior surface. So the anterior surface of the heart is denoted by which leads? It is denoted by V3 and V4. Which leads look at the inferior surface? Now, this is the inferior surface of the heart. So which leads look at the inferior surface? It is your leads 2, 3 and AVF. 2, 3 and AVF. And which leads look at the posterior surface of the heart? The posterior surface is denoted by these leads which are the posterior leads. If you go back and see the lecture on ECGs, you can see that posterior leads are denoted by V7, V8 and V9. Now, why is this understanding of all the surface of the heart and the leads important? Because ST segment elevation MI, STEMI, is basically localized depending on which portion or which leads in the ECG show the corresponding changes. So, a septal MI will have ST segment elevation in V1 and V2. Okay. A high lateral MI will have ST segment elevation in 1 and AVL. A lateral MI will also include V5 and V6. Now, anterior MI will show ST segment elevation in V3 and V4. Okay. An inferior MI will show ST segment elevation in 2, 3 AVF. Posterior wall MIs will show ST segment elevation in V7, V8 and V9. Only the presence of ST segment elevation alone will not help in the diagnosis of a myocardial infarction. So, you should also have corresponding or reciprocal changes, which is nothing but your reciprocal ST segment depression. Reciprocal ST segment depression means the diametric opposite leads will show ST segment depression. For example, if you have a septal MI, there will be ST segment depression in the posterior leads and in V6. If you have a lateral MI, which is your V5, V6, you can have ST segment depression in the inferior leads. If you have anterior MI, which is in your V3, V4, you can have again ST segment depression in V6 to V8 and V9. If you have an inferior wall MI, you can have ST segment depression in the lateral leads, which is 1 and AVL, which is reciprocal changes. Okay. Similarly, a posterior wall MI will show ST segment elevation in V7, V8 and V9. But in your 12-lead ECG, do we have the leads V7, V8 and V9? No. So, what will you see in a 12-lead ECG for posterior wall MI? You will look for ST segment depression where in V1, V2 and V3. Okay. So, this is about the various leads and where do you look for the ST segment elevation and depression. Now, how do you corroborate this with the arterial supply? Now, let us just go through this again. Now, in number 1, which is basically this lesion, okay, just look at the image and look at what I am writing. So, this is your proximal RCA occlusion. So, which walls are affected? This is a proximal RCA, so it results in an RVMI, right? RVMI as well as the inferior and posterior walls will also be affected. So, huge area of the heart is affected. Okay. So, where all will you find ST segment elevation? You will find ST segment elevation in 2, 3 AVF because the inferior wall is affected, and you will find ST segment elevation in lead V1 as well. You will find ST segment elevation in 2, 3 AVF and you will find ST segment elevation in V1 as well. Now, Inferior wall MI. In inferior wall MI, where will be the ST segment elevation? It will be in 2, 3 and AVF. Now, if the PDA in a right dominant circulation is affected, which is your lesion number 2, which I am showing here, you will have the inferior wall as well as the posterior wall affected. So, what are the ECG changes that you will be seeing? You will find ST segment depression in V1, V2 and V3, because ST segment elevation in V7, V8 and V9 is your posterior wall MI, but that cannot be seen on a 12-lead ECG. So, you will find ST segment depression in V1, V2 and V3. Now, inferior wall MI can be because of RCA involvement or left circumflex involvement. Why? Because just now we have seen that if the branch of the PDA is from the left circumflex or your left dominant circulation, it can result in inferior wall MI, or the inferior wall MI can be because of the right coronary artery involvement. So, if the ST segment elevation is in lead 3 is greater than 2, if the ST segment elevation in lead 2 is greater than 3, then this is an RCA involvement. If the ST segment elevation in lead 3 is greater than 2, then it is a left circumflex involvement. Okay. So, let us just revise this once more. We will look at the right coronary artery once before going ahead to the left coronary artery circulation. So, let us just look at the walls. Let us just look at the surfaces and which leads. So, septal leads are by V1 and V2. Yes, you are understanding that septal leads are by V1 and V2. Then, anterior surface is by what? V3 and V4. So, septal leads are by V1 and V2. Anterior surface is denoted by V3, V4, right? V5, V6, 1 and AVL are the lateral leads, fine. And V7, V8 and V9 are the posterior leads, and 2, 3 AVF, because this is how the leads are arranged. So, this is your inferior wall. Okay. So, any ST segment elevation in these leads along with reciprocal changes helps us to localize the myocardial infarction on the ECG. Okay. So, if the lesion is in the proximal RCA, you will have an RVMI. Is that very clear? Because the entire RV is affected. So, if the lesion is in the proximal RCA, what are the symptoms you will have? The first branch of the right coronary to the SA node. So, you can have bradycardia. Then you have branches to the atrium as well as the AV node. So, you can have atrial arrhythmias and you can have conduction blocks as well. Okay. Followed by which there can be ECG changes of inferior and posterior wall MI also if the posterior descending artery is arising from the right circulation, right coronary circulation. And what is the triad of RVMI? It is hypotension, elevated JVP with clear lung field. So, this is one MI in which you have to give IV fluids. Fine. Now, we also learned that inferior wall MI can be due to right coronary artery disease or left circumflex disease, depending upon where the posterior descending artery is arising from. So, how do you identify that on the ECG? If the ST elevation in lead 2 is greater than lead 3, this is an RCA infarct. If the ST elevation in lead 3 is greater than lead 2, this is a left circumflex involvement. Fine. Now, let us look at the localization of the left coronary artery. We have already looked at the branches. Now, first, let us see this lesion, which is the proximal LMCA or the left main disease, proximal left main coronary disease. Okay, so in this proximal left main coronary, all the walls will be involved. So, you can have anterior wall plus lateral wall MI. Plus, if the PDA is arising, you can have a posterior wall MI as well. Which means that you will have ST segment elevation where all? You will have ST segment elevation literally in all the leads. You can have ST segment elevation in literally all the leads and the patient is very, very sick. Okay. Now, let us look at the number 2, which is your proximal LAD proximal LAD, right? So, your proximal LAD involvement is seen. If there is a proximal LAD occlusion, what happens? What happens is that you have the lateral leads, lateral MI plus anterior wall MI plus septal leads. Okay. So, if there is a proximal LAD occlusion, what happens is that the lateral valve is involved, the septal branches are also involved, and anterior wall is also affected. Okay, so you have a lateral MI, anterior wall plus septal MI. So, where all will the ST segment elevation be? It will be in 1 AVL, V1 to V6. V1, V2 is septal, V3, V4 is anterior, V5, V6, 1 AVL is your lateral. So, a huge area of the myocardium is at risk even in proximal LAD occlusion. So, the patient is very sick in proximal LAD occlusion as well. So, now we will come to lesion number 3. So, the lesion number 3 is here. For better understanding, let us just draw the diagram on branches of the LAD again. So, if this is the left anterior descending artery, this is the left anterior descending artery, the first branch that it gives out is the D1 or the diagonal artery, gives rise to the diagonal artery, followed by which you have the S1 or the septal branches, followed by which you have the D2 or the second diagonal artery, and so on. So, you have S2 and S3 as well. So, this diagonal branch is the one which basically supplies the anterior and lateral walls, and the septal branches supply the septum. So, this is about the different branches that arise from the left anterior descending artery. Now, if you want to localize the branches of the left anterior descending artery on the ECG, that is what we are looking at. So, let us look at lesion number 3. The lesion number 3 is between D1 and S1. The lesion number 3 is if there is an occlusion between D1 and S1. If the occlusion is in the proximal LAD, if the lesion is in the proximal LAD above D1, we have already seen it, it can result in a lateral wall MI, anterior wall MI plus septal MI. Okay. So, if the lesion is between D1 and S1, again it causes a lateral wall plus anterior wall plus septal wall, but the high lateral leads are spared. Why are the high lateral leads spared? As you can see, in proximal LAD occlusion, you will have ST segment elevation in 1 AVL as well. But if the lesion is between D1 and S1, ST segment elevation in 1 AVL is not there, it is only in V1 to V6, because the D1 basically is denoted by 1 and AVL. So, if this is spared, the lesion is below the level of D1. So, the leads 1 and AVL will not show any ST segment elevation, rather V1 to V6 is what will show the ST segment elevation. Fine. Now, let us look at the lesion number 4 is basically between S1 and D2. Right. So, the lesion number 4 is here. So, S1 basically is denoted by which lead? V1. So, V1 is also spared, 1 AVL is also spared. So, where will be the ST segment elevation? It will be in V2 to V6. Now, let us look at a condition where only D1 is involved. If only D1 is involved, where will you get your ST segment elevation? ST segment elevation will be in 1 and AVL. Okay. Now, if the left circumflex artery is involved, then it can result in a posterolateral MI. So, you will have a lateral wall MI plus posterior wall MI, which will be characterized by ST segment depression in V1, V2 and V3. Right? What is a wraparound phenomenon? When this LAD goes and wraps around and supplies the inferior wall as well. LAD will supply the inferior wall as well. So, if you have an anterior wall or an anterior lateral MI plus inferior wall MI, it is called as the wrap around phenomenon. It is called as the wrap around phenomenon. Now let us just look at the different localizations again. Fine. Now first we look at the left coronary artery. The left main coronary artery has the first branch. The first branch is your left anterior descending. So proximal left main, if it is affected, then the patient is very, very sick and you have ST segment elevations throughout. Now the second localization is your proximal LAD. Now I have just enlarged the left anterior descending for you. If there is a proximal LAD involvement, which is your number 2, where all will the ST segment elevations be present? It will be affecting the anterior wall, lateral wall as well as septal wall. So 1 AVL, V5, V6, V1, V2, V3, V4. All of them will have a ST segment elevation. Fine. The second, we should be knowing the branches of the left anterior descending. So we have the first diagonal branch, the first septal branch and the other branches. So if the diagonal branch alone is affected, the diagonal branch basically supplies the high lateral walls or the high lateral leads which are 1 and AVL. So if only D1 is affected, then there will be ST segment elevation where? In the leads 1 and AVL. Okay. If the lesion is between D1 and S1, which is what I am showing here, if the lesion is between D1 and S1, then the high lateral leads will not be affected. ST segment elevation will be seen in V1 to V6. It will be seen in V1 to V6. Then let us look at number 4. This is your number 4 where the lesion is between S1 and D2. So this causes ST segment elevation only in V2 to V6 because the first septal branch which is localized by the lead V1 will not show any ST segment elevation because V1 is spared. Okay. So this is about the different localizations of the right coronary and the left coronary artery. Okay. So just to recapitulate, we will be looking at some ECGs as well. So just to recapitulate, let us look at some scenarios. Okay. So you are seeing ST segment elevation in 2, 3 AVF and V1. What is this? We have just learnt this is an RVMI. You have ST segment elevation in 2, 3 AVF only with reciprocal changes. Where do you see this? This is an inferior wall MI. Okay. Now you are seeing ST segment elevation in 2, 3 AVF with ST segment depression in V1 to V3. This is your inferior plus posterior wall MI. So this is about the different types of right coronary circulation. Now let us look at the left coronary. Okay, let us look at the left coronary. So if there is a proximal LAD occlusion, where all will you get ST segment elevation? 1 AVL V1 to V6, almost all the walls, anterior, lateral and septal. Okay, now if there is ST segment elevation only in 1 and AVL, that means what? It's only the lateral leads which are involved. So which branch is involved? It is the diagonal or the first branch, which is your D1 branch. That's what we saw here. Okay. Now the ST segment elevation is in V1 to V6. V1 to V6 basically means what? An anterolateral MI. That means what? Anterolateral, which includes some amount of septum as well. High lateral leads are not involved. If the high lateral leads are not involved, the lesion is below D1. The lesion is below D1 and above S1, above the first septal branch because the septal branch is involved. Now, if the lesion is below S1 as well, that means the first diagonal branch is not affected, the first septal branch is also not affected. So which leads will be involved? It will be only V2 to V6. Okay. So this is about the localization of MI. So let us look at the ECGs. So the first ECG is where all can you see the ST segment elevation? The ST segment elevation is seen in V1, V2, V3 and V4. Right. So the V5, V6 leads are not affected. So, the ST segment elevation is seen in V1, V2, V3 and V4. So, V1 to V4. So, what is this? This is an anterior wall MI. So, this is an anterior wall MI. Fine. Now, let us look at this ECG. You are seeing lesions in, you are seeing ST segment elevation in 1 AVL, V1 to V6 or V1 to V5. So, this is nothing but your anterolateral MI. Anterolateral MI. So, since this 1 AVL is also elevated, this means where will be the localization? It is a proximal LAD occlusion. Okay, this is a proximal LAD occlusion. Let us look at this. You are seeing ST segment elevation where all? With reciprocal changes. You are seeing it in 2, 3 AVF. You are seeing it in 2, 3 AVF. Fine. So, 2, 3 AVF means inferior wall. ST segment elevation in 2, 3 AVF means inferior wall MI. Here, the ST segment elevation in lead 3 is greater than lead 2. ST segment elevation in lead 3. ST segment elevation in lead 3 is greater than lead 2. If lead 3 is greater than lead 2, what does that mean? This means that there is an RCA occlusion. If ST segment elevation in lead 2 was greater than lead 3, then it would have been a left circumflex occlusion. Now, what are we seeing here? We are seeing ST segment depressions. We are seeing ST segment depressions in V1, V2 and this is suggestive of a posterior wall MI. Right? But you are seeing ST segment elevations in 2, 3 AVF as well. So, this is an inferior wall MI along with a posterior wall MI. So, an inferior wall MI with a posterior wall MI. So, this is how you localize the MI on the ECG. Now, let us move ahead. Let us look at what are the other ECG changes which you can find in MI and what we call as the STEMI equivalence. What we call as the STEMI equivalence. Okay. So, first is your, can you see an upsloping ST segment depression? Upsloping ST segment depression with a tall T wave. Upsloping ST segment depression with a tall T wave is what we call as De Winter's T waves and this is a STEMI equivalent. The second is hyperacute T waves. Tall T waves in the leads can be suggestive of STEMI equivalent and this is what we call as hyperacute T wave. Third, we have something called as Wellens syndrome. Wellens syndrome is deep T wave inversions. Deep T wave inversions which are most often seen in leads V2, V3, leads V1, V2, V3 and this is seen in the asymptomatic period. This is seen in the asymptomatic or pain-free period. This is seen in the asymptomatic or pain-free period. During this period, if any patient presents with deep T wave inversions, it is considered to be a STEMI equivalent which is called as Wellens syndrome. So, what happens is that shortly thereafter, this was by observational studies, shortly thereafter they come with a massive MI because of proximal LAD occlusion. So, this is the significance of this Wellens syndrome. Deep T wave inversions in the leads V2, V3 most often in a pain-free period followed by which they end up with a massive MI because of proximal LAD occlusion. So, this is considered to be a STEMI equivalent. Okay. So, that's about the various ECG changes on MI. Now, let us look at the evaluation and management of STEMI. So, let us look at the evaluation and management of STEMI. So, in the evaluation and management of STEMI, first we should be aware of the meaning of acute myocardial injury. So, what is the difference between myocardial injury and myocardial ischemia? In myocardial injury, the troponin I, which is nothing but the cardiac enzymes are more than the 99th centile. The cardiac enzymes are more than the 99th centile and it's characterized by a rapid rise and fall of the cardiac enzymes. Okay, so there is a rapid rise and fall of the cardiac enzymes. But how do you differentiate it from myocardial infarction? In that, myocardial infarctions are characterized by the characteristic chest pain, which is a retrosternal squeezing type of chest pain, which often radiates to the jaw or the left arm, right? So, this characteristic chest pain is there. Also, it shows the presence of Q waves on the ECG, echo evidence of regional wall motion abnormalities. Regional wall motion abnormalities. And there is a thrombus when you do an angiogram. There is a thrombus when you do an angiogram. So, this is how you differentiate acute myocardial injury from acute myocardial ischemia. So, acute myocardial injury, there is only injury. None of these changes are there in acute myocardial injury. But these symptoms of chest pain, Q waves on ECG, echo and thrombus on the angiogram is suggestive of acute myocardial ischemia. Let us move on to types of MI. Let us move on to the types of MI. So, what is type 1 MI? So, the classical MI, which is characterized by thrombus formation or plaque rupture or erosion with the characteristic chest pain and angiogram evidence of any of this is your type 1 MI. Okay. Then you have your type 2 MI. Type 2 MI basically refers to an demand-supply mismatch. Type 2 MI basically refers to a demand-supply mismatch. So, in which conditions you have a demand-supply mismatch? So, this is characterized by the chest pain may or may not be there, but troponin elevation is present and there is evidence of some amount of myocardial injury, in the form of some echo changes can be there. The classical changes may or may not be there, but the echo and ECG changes can be there. So, this happens in conditions such as shock, where there is a demand-supply mismatch, any form of shock, or sepsis, where there is a demand-supply mismatch, and pulmonary embolism, for example. So, in some forms of heart failure as well. So, that is about your type 2 MI. So, let us look at the next type of MI. The next type is the type 3 MI. So, in type 3 MI, there is sudden cardiac death. Okay. So, sudden cardiac death which has been attributed to MI. So, the patient presents as a sudden cardiac death in the emergency. However, suppose there were symptoms of MI prior to the sudden cardiac death, similar to chest pain or history of angina in the past, and then you can attribute the sudden cardiac death to MI, then this is called a type 3 MI. So, in this we don't see a troponin or echo etc. because it's already a sudden cardiac death. Now, sudden cardiac death due to VT or VF is not considered a type 3 MI. There should be evidence of history suggestive of MI prior to the event, and in your post-mortem examination, if there is evidence of a thrombus in the coronaries, then it is suggestive of a type 3 MI. Type 4 MI. Type 4 MI is classified as A and B. Basically, it is a PCI related MI or percutaneous coronary intervention related. 4A is stent thrombosis and 4B is your in-stent restenosis. So, this is a late complication, this is a stent thrombosis. In both of this, we do not take the clinical features into account. Because many of the patients will have an underlying background of coronary artery disease and chest pain in the past, right? So, but new onset ECG changes, ECG or new echo changes are considered along with tropi elevation in a patient who has undergone the PCI with evidence of stent thrombosis on angiogram or restenosis on angiogram is your type 4 MI. Type 5 MI is your coronary artery bypass graft. So, type 5 MI is your CABG related MI. So, this is about the different types of MI. Now, how do you diagnose a case of myocardial infarction? How do you diagnose a case of myocardial infarction? We have already looked at all the ECGs and how to localize the different types of MIs on the ECG. The second thing that we look at is your cardiac enzymes. So, which are the cardiac enzymes that are used? So, the first cardiac enzyme that raises is your myoglobin. The first cardiac enzyme that raises is your myoglobin. Okay, followed by which you have your troponin and CKMB. So, which is the most commonly used one? It is your troponins. So, your cardiac troponins are the one which raise about 0 to 6 hours. So, 6 hours later, up to 6 hours later is when it can start raising, and you see that it peaks up to 1 to 2 days later and then begins to fall. It then begins to fall. So, whenever you show that there is evidence of a rise and fall of the troponins more than the 99th centile, there is evidence of rise and fall of a troponin more than the 99th centile, then you call it evidence of MI or myocardial injury. Okay, so that's about the cardiac enzymes. Now, let us come to the management of MI. So, whenever a patient presents with history or suggestive of MI and symptoms suggestive of MI, acute management in the emergency would be stabilizing the patient. To stabilize the patient, look at the airway, breathing and circulation, look at the pulse rate, the BP, provide supplemental oxygen. You do not provide supplemental oxygen to all patients. You provide supplemental oxygen if the saturation is less than 90% in room air. Make sure that the patient is comfortable. Give them adequate analgesics and pain relief. So, you give them morphine if the pain is very high, and even nitrates which are given sublingually, for the relief of pain. Then we give something called as the cardiac loading doses. So, what are the cardiac loading doses? These drugs include ecosprin. We don't call it ecosprin, it's nothing but aspirin which is non-enteric coated because you want it to dissolve immediately at a loading dose of how much? 325 milligram. Then we give clopidogrel at 300 milligram stat dose, and then you have atorvastatin. At 80 mg dose. So, this is your loading dose. So, the main aim of this loading dose of drugs is that it will help in stabilizing the clot before you take up for your final plan of treatment for myocardial infarction. Okay. So, this is your acute treatment. In your acute treatment, you also localize the MI. In an inferior wall MI or RV MI, there can be evidence of hypotension. So, you treat the patient with IV fluids. Okay. Then you will have to look at the reperfusion strategies. Since there is a coronary artery embolus or thrombus, you will have to look for a reperfusion strategy. The reperfusion can be brought about by thrombolysis or percutaneous coronary intervention. Thrombolysis basically involves administration of an IV thrombolytic agent which will break down the clot. Percutaneous coronary intervention involves placement of a stent. Okay. So, these are the two ways in which reperfusion can be attempted. We have to be aware of the different target times. Okay. So, whenever a patient presents with MI, so the diagnosis of STEMI should be done in less than 10 minutes. Okay. Now, if the patient presents with MI to a non-PCI capable center, that is in a peripheral center or in a community center where you do not have a cath lab, because time is muscle, right? So, there can be delays at every level. There can be delay at the level of the patient has not come to the hospital on time. There can be delay because of the EMS, the emergency medical system is not able to function on time, and there can be a system delay. Since time is muscle and reperfusion is very crucial, we have to ensure that there are no delays in any of these. So, if the patient presents to a non-PCI capable center or a community-based center where you cannot place a stent and you do not have a cardiologist or a cath lab facility, then you have to refer the patient. You will have to refer the patient. You refer the patient how? If you are able to refer the patient to a PCI capable center, if you can refer the patient to a PCI capable center and the time taken to reach this center is less than 120 minutes, you are referring the patient and you know that they can reach the PCI capable center in less than 120 minutes, then you refer them and make sure that the reperfusion occurs less than 90 minutes. Okay, so you do a primary PCI strategy. If you are able to refer and the patient can reach to a PCI capable center less than 120 minutes, then you go ahead with a primary PCI strategy and the time taken for the crossing of wires should be less than 90 minutes. If you feel that the patient cannot reach the PCI capable center, the time is going to take more than 120 minutes, then you please go ahead with a fibrinolysis or thrombolysis. Okay, to go ahead with a lytic bolus of a fibrinolytic agent. Now, if the patient is directly presenting to a PCI capable center, which is a tertiary center with your cardiologist on call, with a cardiologist available, with a cath lab available, you have to diagnose the STEMI with less than 10 minutes and you have to make sure that the wires are crossed in less than 60 minutes. Okay. So, the numbers that you have to remember are 120, 90 and 60. So, in a non-PCI capable center, if you can refer within 120 minutes, ensure that the wire crossing happens within 90 minutes. In a PCI capable center, you ensure that the wire crossing happens in less than 60 minutes. So, this is your total ischemic time to make sure that you are able to reperfuse the patient in less than 3 to 4 hours. Okay, let us look at the second method, which is your thrombolysis. So, thrombolysis has a window of about 6 to 8 hours. Okay, thrombolysis has a window of about 6 to 8 hours. So, the first thrombolytic agent that was used was your streptokinase. Now, we know that from the pathophysiology of MI that there is a clot like this. So, you give an agent which helps in breaking the clot and relief of the symptoms. The first thrombolytic agent which is begun to use is your streptokinase and it is still being used. So, this is a broad spectrum thrombolytic agent. The dose is 1.5 million units over 1 hour. Okay, it's 1.5 million units over 1 hour. So, what are the side effects of streptokinase? Streptokinase is more broad spectrum, so it has a high risk of bleeding. Apart from that, there is an increased risk of anaphylaxis as well. There is a risk of hypotension also. Okay. So, the newer thrombolytic agents are more fibrin specific. So, they have a lesser risk of bleeding. Which are those drugs? Tenecteplase, altiplase and retiplase. Which are those drugs? They are the tenecteplase, altiplase and retiplase. Okay. So, tenecteplase is given as a bolus agent. Tenecteplase is given as a weight-based bolus regimen and it is given over few seconds. Altiplase is given as a double dose. Okay. Now, once you have decided that you want to thrombolize the patient, there are certain other aspects which you have to look into. Okay. So, what are the indicators of successful thrombolysis? You have already given your thrombolytic agent and what are the indications that there has been a successful lysis? The heart rate drops, the BP reduces, the ECG can show downward movement of the ST segment, which means that whatever ST segments were elevated, they come back to normal after at least 1 hour and the pain and other symptoms reduced. So, patient become symptom free. Patients become symptom free. Okay, so these are the indicators of successful thrombolysis. Now, very importantly, what you should be aware is the contraindications for thrombolysis. So, every patient is not suitable for thrombolysis. That is the reason why you should be aware of the contraindications for thrombolysis. So, there are some absolute contraindications for thrombolysis. What are the absolute contraindications? History of intracranial hemorrhage. Okay, history of intracranial hemorrhage. If you are suspecting an aortic dissection, naturally you will not go ahead and thrombolize the patient. History of ischemic stroke and surgery in the past 3 months. Which surgery? Especially spine surgery or closed brain surgeries. Okay. So, in the past 3 months, if there is a history of ischemic stroke or any closed spine or brain surgery, then it's a contraindication for thrombolysis. GI bleed in the past 3 weeks. And aortic dissection we have already looked at. Now, if there is an active malignancy that is going on and if the BP is more than 180 by 120 millimeters of mercury, even then you cannot thrombolize a patient because of an increased risk of bleed. The relative contraindications are use of anticoagulants and active peptic ulcer disease. Okay. So, this is about the contraindications for thrombolysis. Now, once you have thrombolized the patient and there has been a successful lysis, then you have to think about the long-term management of this patient. Okay. Once you have thrombolized and there is a successful thrombolysis, the clot has broken down, then you have to think about the long-term management of the patient. Right. So, we have seen in the risk factors for acute coronary syndrome the presence of hypertension, the presence of diabetes, right, the presence of other risk factors like smoking or alcohol consumption. All of these are risk factors for clot formation or atherosclerosis. So, lifestyle changes plays a very important role in the long-term management of acute coronary syndromes. Okay, so we have to address the hypertension, we have to address diabetes mellitus, make sure that all the comorbidities are controlled. A very important factor is the use of antidyslipidemic drugs, right? So, we use statins in the management of ACS. Then, drugs, ACE and ARBs. We know that from our chapter on heart failure that ACE and ARBs have a very good effect because they prevent the cardiac remodeling. So, they decrease the cardiac remodeling in a post-MI patient and they also reduce the BP. So, they are also antihypertensive agents. So, ACE, ARBs are definitely indicated. Also, the use of beta blockers. Beta blockers are also very important and they form a very important part in the management of MI. Then, antiplatelets. So, you use dual antiplatelets. Which is ecosprin and ticagrelor. Ticagrelor is preferred over clopidogrel. So, ticagrelor is preferred over clopidogrel. So, a dual antiplatelet strategy is used for 1 year and followed by which you can switch to a single antiplatelet, and this is a lifelong therapy. Then statins. Statins are high dose statins, right? High dose to moderate dose statins are used and the target LDL would be to less than 70 milligram per deciliter. To target an LDL of less than 70 milligram per deciliter, right? So, this is about your long-term management of ACS or post-myocardial infarction patients. Now, let us understand what this percutaneous coronary intervention is. Now, always remember that a percutaneous coronary intervention is always a better option when compared to a thrombolysis because the thrombolytic reagent always has its own risks, right? So, percutaneous coronary intervention is a better option. And in those patients where the thrombolysis did not work, in those patients where the thrombolysis has not been effective, you can also do a rescue PCI. You will also do a rescue PCI where you immediately take up the patient for PCI. So, what do you do in this percutaneous coronary intervention, we do something called as the Seldinger's technique. We do something called as the Seldinger's technique, where you take a puncture through the radial or femoral artery, right? So, you take a puncture to the radial or femoral artery and you put a guide wire through it. So, once you put the guide wire, it goes to the coronaries. And you load a stent or balloon. On the guide wire. So, if you see in this image, the balloon basically crosses the lesion, right? If you see in this image, the balloon basically crosses the lesion and then it expands and the plaque is pushed aside. So, this in essential restores the flow. Similarly, you can also place a stent, right? So, this is what we call as the percutaneous coronary intervention. This is your coronary artery and you place a stent or balloon so that you bypass what is called as the plaque. You bypass the plaque and you restore the flow. Okay. Recently, there have also been drug-eluting stents. You can also find drug-eluting stents, and this is which drug is used? It is your sirolimus and everolimus. Fine? Okay. Now, once you do a PCI, how do you know whether the blood flow has been restored? The blood flow has been restored? So, this is given by the TIMI flow. The TIMI grading is used to find out whether the blood flow has been restored following a PCI. So, grade 0 means that there is no flow beyond the occlusion. Grade 1 means that there is a faint flow. Grade 2, there is a sluggish flow, and grade 3 is your normal flow. So, what will you target? You will obviously target achieving a TIMI grade 3. Now, though I have explained the percutaneous coronary intervention in simple words, it is always not so easy. So, there are various factors which influence the PCI. It depends upon the anatomy of the vessels. It also depends upon the calcification of the vessels, and it also depends upon the number of vessels that are involved. Okay. So, if the vessels are very calcified, what happens is that you cannot put a stent or a balloon because they have become hard. So, in those cases, or if the number of vessels that are involved are more than 3, you will have to take them up for a coronary artery bypass graft. Okay. So, that is about your percutaneous coronary intervention. Fine. So, let us look at the complications of myocardial infarction. So, now what all have we learned? We have learned about the management of MI. We have learned about the acute management, the target times. How do you obtain your reperfusion? Do you take up a thrombolysis strategy or do you take up a PCI strategy? Okay. Then we have looked at the contraindications for thrombolysis and we have looked at the percutaneous coronary intervention as well. Now, let us understand what are the different complications of myocardial infarction. So, post MI, you can have multiple complications. The first is your hemodynamic complication. So, in your hemodynamic complication, you can develop an acute pulmonary edema. So, when do you develop an acute pulmonary edema? When there is a pump failure, when more than 25% of the myocardium is involved, you can develop a pump failure, or with the development of an acute MR. When do you develop an acute MR? So, you would have seen in the chapter of mitral regurgitation that in inferior wall MI, there can be rupture of the posteromedial papillary muscle. So, when there is an acute papillary muscle rupture, you can develop an acute MR, right? So, whenever there is an acute MR or there is a huge area of the heart which is involved because of a huge infarction, they can develop acute pulmonary edema. So, how do you treat this? How do you treat this? The patient is very sick. So, you give them a low dose of diuretics. You give them a low dose of diuretics and you give drugs that decrease the afterload. You give drugs that decrease the afterload, and you definitely, if there is an acute MR, take them up for surgery. If there is an acute MR, you have to take them up for surgery. Second, cardiogenic shock. The second hemodynamic complication of MI is the cardiogenic shock. When more than 40% of the myocardium is involved, when more than 40% of the myocardium is involved, then you can develop a cardiogenic shock. In cardiogenic shock, you can use ionotropes. If they are not responsive to ionotropes, you can use assist devices. You can use assist devices such as an intra-aortic balloon pump. Intra-aortic balloon pump is an assist device and it helps in maintaining the cardiac output. It is a temporary device till a point where the shock recovers. Okay, so that is about the hemodynamic complications. Let us look at the mechanical complications of MI. So, the first mechanical complication can be in less than 24 hours to up to more than 4 days, you can have a septal rupture. You can have a septal rupture. If the septum is ruptured, what is it similar to? This is similar to a ventricular septal defect, right? So, it can also have an associated severe tricuspid regurgitation. It can also have an associated severe tricuspid regurgitation. Okay. So, in ventricular septal defect or septal rupture as well, you need to take them up for an emergent surgery. The second mechanical complication is that there can be a free wall rupture. There can be a free wall rupture in LAD involvement. There can be a free wall rupture in left anterior descending artery involvement, and this can result in a tamponade. There can be rapid filling of the blood and can result in a tamponade. In this condition, the patient is very sick, and when you do an echo, you find a tamponade and you have to surgically treat them. The third mechanical complication is your acute MR. Just now we have discussed posterior medial papillary muscle involvement, and it is commonly associated with inferior wall MI. So, acute MR is again treated with decreasing the afterload and taking up the patient for surgery. In acute MR, you find that there is a pansystolic murmur in the mitral area. In septal rupture, you can find a pansystolic murmur in the parasternal area. Okay. Now, they can have arrhythmias. Electrical complications is also seen in post-MI patients. So, first type of arrhythmia, you can see sinus bradycardia. Where do you see it? You see it in inferior wall MI, because inferior wall MI can be caused by right coronary artery, and the right coronary artery first branch is your SA nodal artery. Apart from that, you can also have AV blocks. AV blocks are also seen in inferior wall MI and RVMI. Okay. Then you can have AIVR. What is AIVR? It is called as accelerated idioventricular rhythm. Accelerated idioventricular rhythm. So, what happens here is that there is a ventricular rhythm or a junctional rhythm which happens in MI. But is this a bad prognosis? No, this is suggestive of successful thrombolysis. So, sometimes in patients there can be a AIVR, and this is suggestive of successful thrombolysis. Okay. Then, the third type of arrhythmias you can have is your VT-VF, especially in extensive anterior and lateral wall MIs, you can have VT and VF. A primary VT-VF is one which occurs less than 24 hours, and secondary is the one which occurs after 48 hours, right. So, these VT-VF can be controlled with antiarrhythmic drugs like amiodarone. Okay, but if there is recurrent VT-VF and if the EF is too low and if there is a risk of sudden cardiac death, then you may have to place an ICD. Okay. Then you can have complete heart blocks. Complete heart blocks in an inferior wall MI, is it common? Uncommon. This is common. and generally the patient is stable and does not require any treatment. But the same complete heart block, if it happens in an anterior wall MI, the same complete heart block, if it happens in an anterior wall MI, then you will have to put in a permanent pacemaker. You will have to put in a permanent pacemaker. Okay. So, till now we have learnt the hemodynamic, the mechanical complications and the arrhythmias which can be seen in an MI patient. So, now under the complications of myocardial infarctions, we have learnt about the hemodynamic, the mechanical and the arrhythmias which are associated as the complications of MI. Now, let us learn about the pericardial complications. So, the late pericarditis, the late onset pericarditis that occurs after a myocardial infarction is called as the Dressler's syndrome. So, a late onset pericarditis that usually comes after 4 to 8 weeks is called as a Dressler's syndrome. So, how does the Dressler's syndrome present? It presents with a typical pericardial chest pain. Most often, the treatment is with aspirin. Treatment is with aspirin, and generally it's a high dose aspirin. Okay, fine. Now let us go to the next important complication, which is your LV aneurysm. So, aneurysm can be classified into two types, a true aneurysm and a pseudo aneurysm. It can be classified into two types, which is your true aneurysm and your pseudo aneurysm. So, in a true aneurysm is commonly associated with an anterior wall MI. It's commonly associated with an anterior wall MI where you have a thinned out and a dyskinetic segment. You have a thinned out and a dyskinetic segment, and all the three layers are involved in the formation of the aneurysm. All the three layers are involved in the formation of the aneurysm, and the treatment is often conservative for a true aneurysm, right? So, you can find this on the echo, and treatment is often conservative. But a pseudoaneurysm is more dangerous. A pseudoaneurysm is more dangerous. This is associated with a free wall rupture. This is associated with a free wall rupture, and it presents as a coagulotamponade. It presents as a coagulotamponade. So, what happens is that there is some amount of bleeding and it clots. The clot seals off this rupture, and hence it appears like an aneurysm, and this is a pseudoaneurysm. But any time the pseudoaneurysm can give way and can result into a massive tamponade. That is the reason why the treatment for a pseudoaneurysm is surgical. So, with that we have understood what are all the complications of a STEMI. Let us understand the management of NSTEMI. So, in an unstable patient, if the patient is in shock, the patient is in failure secondary to the NSTEMI, then you do an urgent CAG, you do a urgent coronary angiogram, and you put the stent in less than 2 hours. If the patient is stable, then you can try medical management. So, what are the drugs? You give your loading dose, similar to that of the STEMI, you give your loading dose and you give aspirin at 300 mg, you give clopidogrel. Here the loading dose is slightly different, it is 600 mg, and you give your statins at 80 mg. NSTEMI requires an anticoagulation protocol. So, which is the anticoagulant which is used? It is the enoxaparin at 0.5 mg per kg bolus dose. So, you give the enoxaparin and then you take up the patient for the cath lab. So, this ensures that the thrombus does not worsen. In the long-term management of an NSTEMI also, the patient goes on a DAPT or a dual antiplatelet therapy for 1 year, followed by a lifelong single antiplatelet along with a statin. Then you do give your guideline directed therapies such as ACE inhibitors, ARBs and beta blockers, which have a mortality benefit. What is the role of anticoagulation in STEMI? Peri-procedural, you can give anticoagulation, and what we give is your heparin or bivalirudin. Okay, you give heparin or bivalirudin. Post thrombolysis, you have a raw area. So, that can result in the formation of clots as well. So, post thrombolysis also you give anticoagulation, which is usually a low molecular weight heparin. You can give low molecular weight heparin, which we generally give for up to 4 to 5 days. Or post thrombolysis, we give up to a time when the patient is bedbound. Okay. So this brings us to the end of this chapter on myocardial infarction. We have learned about the management of STEMI, management of NSTEMI, the various complications and how do you manage the complications. Okay. Thank you.